Hello everyone. Today I would like to present two interesting cases. The first case, she is a 48-year-old female. She had Graves, that is multinodular goiter with thyrotoxicosis and thyroid associated ophthalmopathy. She presented with a progressive numbness of both lower limbs since 4 days, difficulty in walking also for the past 2 days, and she has associated upper limb paresthesia and numbness. Examination showed that she was fully conscious and oriented with bilateral exophthalmos and dry eyes. She had a bilateral low motor neuron type of facial weakness. Power in the upper limbs were around 3/5 proximally and distally, and similarly in the lower limbs the power is the same, nearly 3/5. A grip were grossly weak bilaterally. She had generalized areflexia and plantars were flexor bilaterally without any sensory loss, neck stiffness, meningeal signs, autonomic involvement, and other systems were within normal limits. The nerve conduction studies showed demyelinating polyradiculoneuropathy with conduction block. You can see that there are demyelinative changes, there are conduction block in various motor nerves with a normal sensory conduction. CSF study done showed a 26 milligram percentage and cell count were 5 lymphocytes. This albuminocytolical dissociation, that is protein more than 100 and cell count less than 10. Her ANA was negative, serum protein electrophoresis showed elevated gamma globulin but no imbalance. Her cardiac status were normal, echo was normal, she had only sinus tachycardia. So she was promptly started on intravenous immunoglobulin 400 milligram per kilogram body weight. And in the ICU, she started developing various complications like respiratory distress, autonomic dysfunction, with episodes of bradycardia, tachycardia, sweating, and all sort of autonomic involvement. And she was immediately intubated and ventilated. And next day, she developed sudden cardiac arrest, and CPR and ALS was initiated, and she remained in coma for afterwards, and her Glasgow's coma scale was E1, M1 and VET, that is a 3/3 out of 15, that means just like a brain death. We did an MRI, we showed there are ischemic changes in the frontal lobes around the central sulcus, in the hippocampus, as well as in the temporal lobes. And she was tracheostomized after a few days, and gradually she made a gradual recovery and weaned off from the ventilator after 1 month, and she was later shifted to the ward. She was also started on dabigatran for DVT prophylaxis. This is the patient, and at the time of discharge she was fully conscious, oriented, able to swallow, and power has improved remarkably. Upper limb was 4/5 and lower limb was 3/5, and she was reviewed after a month, and she was found to be ambulant and was functionally independent. So the clinical diagnosis was Guillaine Barre syndrome with respiratory paralysis, autonomic dysfunction with the cardiac asystole, hypoxic ischemic encephalopathy, hyperthyroidism, and Graves. So Guillaine Barre syndrome is a low motor neuron disorder with proximal and distal weakness, areflexia, and the nerve condition shows demyelinative or axonopathy changes with conduction block. And this represents a broad group of demyelinating disease like inflammatory polyradiculoneuropathy. And there are so many types of there. You have acute inflammatory demyelinating polyradiculoneuropathy, AMAN, that's acute motor axonal neuropathy, that's the Chinese variant, or ASAN, acute sensory axonal neuropathy, or AMSAN, acute motor sensory axonal neuropathy, Miller-Fisher syndrome, Miller-Fisher type plus, as well as various topographical variant like bifacial variant, pharyngocervical variant, bibrachial variant, autonomic variant, paraparetic variant, and pure axonopathic, pure demyelinative, or with the conduction blocks. Many types were described. And the clinical criteria is the clinical weakness with reaching the nadir of symptoms within a month, related to symmetry, mild sensory symptoms of signs, cranial nerve involvement, and recovery starting after 4 weeks, autonomic dysfunction, and absence of fever at the outset. And as well as CSF showed albinocytological dissociation, and the electrodiagnostic features of condition slowing, condition block, prolonged distal latencies, slowed condition velocity, absent F5 response with almost sural sparing and absent ulnar snap. And this should be careful when you find this thing like a marked asymmetry or persistent autonomic dysfunction or cell count more than 50 or polymorphonuclear leukocytes, or if there is sensory level. So if these features are there, you should be extremely careful. You should look out for other cause like spinal cord disease like myelopathy or some other HIV, thyrotoxicosis or lymphoma, sarcoid, and many other conditions. So as I mentioned earlier, there can be a man only motor neuropathy, Amsan with motor and sensory neuropathy, Miller-Fisher is ophthalmoplegia, reflection, ataxia, and acute pan dysautonomia, that is a pure autonomic neuropathy with both sympathetic and parasympathetic, pure sensory type, and pharyngocervical type, paraparetic, bibrachial, bifacial, and many other newer variants. So what are the various complications of Guillaine Barre syndrome? You know that apart from the respiratory paralysis, they can have autonomic dysfunction, bladder and bowel may be affected initially up to 10 to 30% of the cases. They can have associated SIADH, syndrome of inappropriate ADH secretion, and lower backache, because especially if the sensory roots are affected, they present with extremely severe low backache. Okay, and they can have pain, autonomic complication, the residual numbness or the sensation, DVT due to immobility, pressure source, relapse can occur in 2 to 5%. I have seen a couple of cases with relapse. There is one entity called SIDP, that is subacute inflammatory demyelinating radiculoneuropathy, but you know, that is an entity between AIDP and CIDP. So there can be autonomic complication like in this case. This is extremely rare because I have never seen a case of a cardiac arrest occurring in the context of a autonomic complication and causing hypoxic ischemic encephalopathy. Many cases, maybe a few cases in the pediatric age group, when I search, you can see that superimposed Guillaine Barre syndrome in pediatric hypoxic brain injury. It's a research article, and the case reports that patient is a 16-year-old boy had cerebral hypoxia secondary to strangulation, subsequently developed Guillaine Barre syndrome. So it means that hypoxic brain injury has been reported, though it's extremely rare. So the autonomic involvement, you know, they can involve many systems. They can involve the eyes, it can involve the secretion, the cardiac, the respiratory, GIT, the autonomic system in general. And the PubMed search yielded around 193 results, and you can see that it has been reported extensively, but the so-called asystole, cardiac asystole, given that this and with the full recovery is, I think it's extremely rare. So I just would like to present this case considering the rarity of the case as well as the various interesting clinical features. Thank you very much.